Okay, are we good to go? Right, IT, we're live. Lovely. Good afternoon, everybody, and welcome to the last of the very successful CT forum session today. We've got 8 presentations, and then we're going to also finish up with a talk from our new lead for nursing and allied health professionals, Bhavana. So what I'd like to do is just introduce you to this session and our chairs. So if I could just go around and let our chairs introduce themselves. Nora.
Hi, my name is Nora May. I'm one of the thoracic SPRs in Harefield Hospital.
Thank you, Nora. And Catherine, please. You're on mute, Catherine.
Sorry.
That's all right. Don't worry. Off you go.
I'm Catherine. I'm one of the advanced practitioners working at Queen Elizabeth Hospital in Birmingham.
Thank you, Catherine. And this is Simon Kendall.
Good afternoon, everyone. Simon Kendall, cardiac surgeon in Middlesbrough and the current president of SCTS.
Thank you, chairs. So we're going to have presentations, our 8 presentations on advancing roles and evolving services. So essentially, we've got a nice group of presentations that are going to basically look at human and structural resources on how we can make our CT surgery as good as it is and much better than we hope it can be, sort of thing. So I'm going to ask each of the presenters to come at the end of their session for their questions and answers. So if it's all good with our IT, we would like to move to the first presentation, and I'd like to introduce Maxine Reed. And Maxine and her colleagues have put together a presentation on introducing an innovative electromagnetic navigational bronchoscopy service to a regional centre, the experience of a multidisciplinary team. And I'm going to suggest to the presenters that they didn't write that after a glass of wine, that title. So off we go then. Thank you very much.
Hi, my name is Maxine. I'm one of the surgical care practitioners in Hull, and I've just got a few minutes to tell you a little bit about our electromagnetic navigational bronchoscopy service that we introduced last year. So who are we? We're a regional centre covering quite a wide geographical area, and we're one of only 7 centres in the UK that offer a navigational bronchoscopy service. So what is NavBronch? Well, a conventional flexible bronchoscope is quite a thick instrument because it combines a light and a camera. And it's introduced into the patient airways, and because of its thickness, there's only so far that it can travel down, meaning that peripheral airways we're unable to access. The NavBronch overcomes that problem by using the patient's CT scans to build up a 3-dimensional map that can be then used to create a virtual roadmap for the consultant to view as he's able to advance a much finer tool into the fine airways. So this screen aims to try and tell you a little bit about how that's achieved. There's a stack with the computer on, which is part of the system that you get. The first part of this is the consultant views the patient's CT scans, and on those identifies the target lesion, puts a little green target onto it. And then also he then needs, or he or she then needs to identify the airways that are going to lead us down to where that lesion sits. So the surgeon then plans the airway using the software, and that's then logged in there awaiting the next part of the process, which is when the patient comes to theatre, is anaesthetised and laid on a table with some plates beneath them that set up an electromagnetic field, creating a sensing volume, which then allows the process of registration to begin, which is where the conventional bronchoscope is introduced with the locatable head that's part of the system. And the main anatomy is identified, so the surgeon can see on the bronchoscope screen that he's, say, at the marine carina, and then on the virtual image that those are overlaying, so that we can be confident that what we're seeing on the screen on the virtual pathway is actually relates to the patient's own anatomy. And once that's been done, the surgeon follows the pathway that has been identified all the way down to the lesion, which can then be biopsied. So this equipment can also be used for conventional surgery, so for some peripheral lung nodules where it can be very, very difficult to feel them, even once you've opened, or see them. And the consultant would normally then just be relying on looking at the CT scans and trying to gauge in the patient's own anatomy where the nodule would be. If we do the nav bronch beforehand, we can put some dye directly into the tissue around that nodule, navigating with the system. And then when we flip the patient over onto their side, put the camera in, it's as easy as seeing blue dye there. That's the bit we need to take out. So the service was introduced into our centre a little unconventionally, in that the consultant surgeon, instead of inviting registrars or even his consultant anaesthetists to go with him to get to the training, he invited nurses and allied health professionals, the theatre team, to come. And I think, although that ruffled some feathers at the time, it certainly gave us benefits going forward. And I've put some main learning points on the screen for you. So our results were pretty good. 65% of our patients who had the procedure, we were able to obtain a diagnosis. Nationwide, anything over 50% is considered quite good. We were hoping for 100% of our patients to be day cases, but some required chest drains and some were just kept in for social reasons. So the conclusions, the results are there. Interestingly, the patients we were able to obtain malignant diagnoses for them, 64% of them were not fit enough to have had conventional surgery, but they were then able to benefit from oncological treatment. What next for this team? We'll carry on working together and learning from and with each other. And we hope to get an upgrade to our system, which will then improve our diagnostic yield. Thanks ever so much for listening.
Laura, thank you.
So I'm very sorry I couldn't hear the rest of the presentation. Thank you very much, Mrs. Reed, for your interesting presentation. What are the main indications, or are there any other indications apart from nodules where you're using that innovative electromagnetic bronchoscopy for?
I might hand that question over to Mr. Tentzeris, who's actually sitting next to me, so he could answer that.
Hello.
Good afternoon.
Hi, I'm not a thoracic consultant here. So the main indication is to aim to diagnose nodules that they won't be accessible by conventional either bronchoscopy or CT-guided biopsies. So any nodules that are behind bony structures or very close to the diaphragm, very close to the mediastinum, or on an emphysematous lung that the radiologist will not put a needle, or next or crossing a big vessel, anything that is not making comfortable a chest physician or a radiology consultant will come in. So that is on regards to the diagnostic process. And as Max has said, we have found that it's very helpful, not only for those who are future surgical candidates, but it made a big impact to those who are not surgical candidates. So those who could withstand a 10-15 minute anesthetic to have a quick diagnosis, and beforehand they wouldn't have any option of any sort of treatment. The MDT would give them for best supportive care. Now with all the tumor markers we can get, they actually get a treatment. So that made a big difference to those patients. And the other is assisting the surgeon, as we said, with the company Medtronic says fiducial markers. I found them not very helpful, but the methylene blue dye is, if you do a quick localization before it becomes a Smurf's lung, then it is very helpful to localize ground glass opacities that you won't be able to palpate, or those tiny little nodules. So it's a very interesting tool.
Thank you. Nora, can I just check, with 1 minute left, have we got any questions in the Slido?
There's no question. There's one about lesions.
Can I ask? Really impressive the way you've got this up and running, and the outstanding results that you've got. What could you share with us, having done this? What would you do anything different next time to how you've introduced it, or are you happy how it's all gone?
I was going to ask what the biggest challenge was, so well, two minds think alike.
I think we found it a bit of a challenge keeping the team together, given that the pandemic kind of happened just after we'd started. So it's useful. There's a group of us knew how to do it, and trying to keep that same team there so that there was some consistency and we weren't trying to repeat the same mistakes over and over. That was quite a challenge. But from my point of view, I don't know what Mr. Tentzaris is going to say, but I think it had such advantages going with the allied health professional nursing sort of a theatre team as opposed to the Regis, because we're there more reliably maybe than the Regis are, who are rotating round, if that makes sense. I don't know if you'd agree.
No, I totally agree. That's why I insisted, and I had negotiated with the company to bring with me in Belgium not registrars, but the nurses and the advanced care practitioners and the surgical care practitioners and the ODPs of theatre, that they will be there and they can pass the torch to the next guy in theatre. That was important, to disseminate the knowledge. On regard to challenging, the most challenging thing was the histopathologist, because we introduced a new technology, and now the histopathologist had to do 16, 20 samples per case. And because it's a quick procedure, we could, before the pandemic, we could easily do 4 or 5 of them and then do our 2 or 3 lobectomies. So it is literally a 15-minute procedure, and that put challenge to the histopathologist. So yeah, that was the biggest problem of the MDT.
Well, could I say thank you to Maxine and the team? That was a lovely presentation. We're going to, thank you, move to our next presentation now. I'd like to welcome Michelle Gibb. Michelle is going to give us a presentation on physiotherapy after surgery for malignant pleural mesothelioma, clinical attitudes to a single centre, UK centre. So I'd like to welcome Michelle, please, and her presentation.
Hi, my name is Michelle Gibb. I'm a clinical specialist physiotherapist working in thoracic surgery at Glenford Hospital in Leicester. And today I'd like to present our team's work on physiotherapy after surgery for malignant pleural mesothelioma, clinicians' attitudes at a single UK centre. So to give you some background, patients who undergo surgery for mesothelioma are at risk of developing post-operative pulmonary complications, physical deconditioning and multifactorial breathlessness. These factors may prolong a hospital stay, delay patient recovery and increase morbidity. So physiotherapy management of patients who undergo mesothelioma surgery is key to aid recovery and build on post-operative quality of life. However, at present, there is very little literature detailing physiotherapy interventions after mesothelioma surgery. Glenford Hospital is one of the largest centres in the UK to undertake surgery for both major and minor mesothelioma surgery. So we sought to investigate the multidisciplinary clinicians' perspectives on physiotherapy practices after surgery for mesothelioma at our specialist thoracic surgical unit in the UK. So we designed and distributed an online questionnaire and then split the questions all into major surgery and minor surgery, of which we utilised definitions from the International Association of the Study of Lung Cancer, which define major surgery as an extrapleural pneumonectomy or an extended pleurectomy and decortication, and minor surgery as a pleurectomy decortication, partial pleurectomy decortication and pleurodesis. So our questionnaire inquired about physiotherapy interventions from all aspects of the surgical patient's journey, so from pre-op, intra-op, post-op and follow-up and aftercare. So our questionnaire was sent to our specialist MDT, of which 32% of responders were surgeons and doctors, 8% were physiotherapists, and largely our responders were the nursing team of 60%. So we found that 89% of our responders were aware of currently used airway clearance interventions, such as active cycle of breathing, PEP, mobilisation for airway clearance and the use of relevant nebulizers as well. However, 40% of our responders didn't know that we provided energy conservation advice to our patients, and this is a really important part of facilitating discharge and recovery, so it's highlighted a learning need there. Our questionnaire also wanted to identify what the MDT felt were the main challenges post-operatively for physiotherapy. 40% of our population identified cardiovascular instability, and then the next highest was pain of 28%. So an interesting school of thought is that after diaphragmatic resection within the major surgical mesothelioma group, diaphragmatic patching does limit the appropriateness of positive pressure physiotherapy interventions, such as intermittent positive pressure breathing. A lot of people know this as the bird. It's felt that the positive pressure airflow may lead to disruption of the diaphragmatic patch. However, there's very little evidence to prove or disprove this theory, but our responders did agree, with 78% agreeing that they felt the diaphragmatic patching would limit how appropriate positive pressure interventions would be. So in our centre, we don't routinely use positive pressure interventions with our major surgical group after surgery for mesothelioma. However, it is clinically reasoned on an individual basis, and it's always discussed with the operating surgeons as well. So we really wanted to know about future aspirations for surgical mesothelioma patients and physiotherapy, and our responders identified that having more preoperative information about physiotherapy and having more of a physiotherapy presence in pre-op clinics would be a really great way forward. This is something we don't currently do, but a really good thing to look at in the future. And prehabilitation was one of the most identified quality improvement areas in this patient group. So prehab's a really essential way of really optimizing our patients before surgery and aiding their recovery. So something great to look into as well. So in conclusion, there's variable awareness of current local and safe physiotherapy practices following surgery for mesothelioma by our MDT. So we'd really like to take this project further. So what we'd like to do next is take this survey nationally to our colleagues across the UK. So please keep an eye out in your emails and please get in touch if you'd like to be involved. From this, anybody would like to be involved, we'd like to invite to a focus group to discuss and share best practice, with the overall goal of formulating and developing best practice guidelines for physiotherapy management of mesothelioma patients. So thank you so much for listening. If you've got any questions, I'd be happy to answer them. And if you'd like to be involved, please do get in touch. Thank you.
Hello, and thank you so much, Michelle, for that fantastic presentation. I would just like to start by just saying how important physiotherapy is for all of our patients post cardiothoracic surgery, and I think it is so underestimated in a lot of areas. So this presentation is fantastic. So well done.
Oh, thank you so much.
And I'd just like to open up to anyone who's got any questions. And can I ask people to submit questions as well, because there's none come through at the moment.
So just while we're waiting for questions then, thank you very much, Michelle. That's a really good presentation, and it's very topical, isn't it, at the moment? And I think your way forward for engaging the MDT is really important. How do you think, I suppose, for units that don't have 24/7 physiotherapy, how do you think you can engage the rest of the MDT so that all the sort of the prehab isn't lost in the post-operative period?
Thank you so much, and that's a great question. Thank you. So I'm so lucky with the unit that we're working in Leicester, that the MDT are just fantastic, and like they've really bought into like the importance of physio. But I think it is about education to the team as well, and when you can show those benefits of somebody being up and out of bed and how beneficial that is for their chest clearance, increasing their lung volume, and just ongoing with their sort of recovery as well. So hope they going through with your MDT, sort of the importance of it, and it's nice for them to see the results as well of people who you probably look at somebody in the bed and think, oh, perhaps they might make it to the chair. They've got a lot of attachments. They're not particularly mobile. But to see them walk down the corridor and then the impact that has on them as well, and the impact of hopefully like reduction in oxygen, and as we start to lose attachments as well. So I think having that MDT buy-in, and I think it was really refreshing from our survey to see of how much the MDT does know about physiotherapy as well. It was really lovely to see that all that pestering I do of them. And but no, I'll say I'm so lucky in the MDT that I've got, and I'm sure other physios around the UK are the same as well.
Thank you, Michelle. I was about to say, you know, if we can see people with intra-aortic balloon pumps skipping down the corridor, then,
Yeah.
and when you think of the emotional elements of the underlying diagnosis for the mesothelioma patients, getting them up, I think, has a huge benefit. So, can I just, if Catherine hasn't got any more questions from the side, can I just check with the panel if there's any other questions? Mr. Kendall, thank you.
Hi, Michelle. I think this is a challenge for all of our patients. I don't know about congenital, but certainly adult cardiac and thoracic, getting them moving. And it just seems there's so much reluctance to take off the oximeter and the blood pressure cuff. And did you have any difficulties with those conversations or negotiations, or was that all sorted out at the MDM level?
I think, no, you're quite right. And I think particularly with our, a lot of our surgical patients, but particularly our mesothelioma patients who have undergone extended perectomy and decortication, they come out with 5 chest drains, an epidural, an NG drain. So it can be really daunting for patient and staff sometimes getting these patients out of bed. And I think having that preoperative engagement from the patients as well, so with enhanced recovery and presenting our patients with as much information and enabling them to have to have more of an understanding is really important too. So our thoracic nurse specialists in Leicester do a fantastic job of preoperatively saying, no, Michelle and her team will be round to get you out of bed, often make a joke out of it, as us physios do, but yes, saying, you know, it's really important, this is why we do it. And I think, Tara, you said as well about for the mesothelioma patients, this is kind of their last resort really with this operation. So they generally, we do get a lot of patients are very motivated. They do want to get up and moving. And I think that education and support from the MDT, and staffing wise, from our survey, it was identified sort of the number of attachments and sort of the cardiovascular instability can be quite worrying for nurses, say, to get patients out of bed. So within Leicester, if we've got any new starters, that physios or nursing staff, healthcare assistants, we try and double up and just increase some confidence really, and look at what we'd look for in cardiovascular instability, what would maybe make us push a patient a little bit harder, or what might us maybe say, okay, let's stop there for now.
Thank you, Michelle. That's really good sort of instructions for us to take away. Thank you for your presentation today.
Thank you so much.
Thank you then. I'm going to move to the next presentation and invite to the floor Katie Lyon and her colleagues. And I think actually it's probably going to be Fiona Nolan that's going to present for the presentation. And it follows on really nicely because it's prehabilitation in cardiothoracic surgery. So thank you, Fiona. Is it Fiona I'm welcoming?
Hello, my name is Katie Lyon. I am a senior physiotherapist from the Golden Jubilee National Hospital. Today, I'm going to speak to you about the effect of a physiotherapy prehabilitation programme on postoperative outcomes in patients undergoing cardiac or thoracic surgery, the results from our pilot study. First of all, a little bit about who we are. The Golden Jubilee National Hospital is home to regional and national heart and lung services in the west of Scotland. We are a national waiting time centre and carry out approximately 1,400 major heart surgeries and 1,200 lung procedures every year. In 2014, the physiotherapy team carried out a scoping exercise with our patients before the introduction of our preoperative education classes. The scoping exercise highlighted to us that our cardiac and thoracic surgery patients have a fear of exercise before surgery, believing that they will cause themselves harm exercising before the surgery is performed. We obviously know that the opposite is true, and not being physically active or exercising leads to deconditioning, loss of muscle mass, and pulmonary complications, effectively lowering a patient's baseline level of fitness. Prehabilitation aims to prevent this physical decline. The waiting time between acceptance for surgery and the surgery itself provides a teachable moment, a period of time where patients improve their physical fitness through a guided exercise programme, as well as implement lifestyle changes with the aim of increasing their baseline. The fitter and stronger a patient is going into surgery, the better the post-operative outcomes. Prehabilitation has become well established in other surgical specialties. However, a few years ago, there was a lack of evidence to support its use in cardiac and thoracic surgery. Studies were limited to small sample sizes and mainly class-based, reliant on being led by a physiotherapist, which would not be feasible at the Golden Jubilee. Research suggests that home-based programs are feasible and safe with comparable outcomes to supervised programs. However, there is limited evidence to support home-based programs in thoracic surgery. So the research team set up a pilot study looking at a home-based physiotherapy prehabilitation program for cardiac and thoracic surgery patients. The aim was to determine whether a home-based physiotherapy prehab program improved patients' functional capacity measured by a 6-minute walk test before surgery and improved post-surgical recovery. 40 patients in total were recruited, 20 for the thoracic arm and 20 for the cardiac arm of the study. Within each arm of the study, participants were randomised into 10 participants for a standard care group and 10 into a prehabilitation group. The prehabilitation group received a home exercise programme of an incentive spirometer, deep breathing exercises, a pedometer, a walking programme, and a patient diary to record their activity and tidal volumes. Changes in baseline functional capacity were measured by a 6-minute walk test. The results from the cardiac arm of the study showed that the mean physiotherapy length of stay was reduced by more than a day, and the total hospital length of stay approximately a day for the prehabilitation group. The prehabilitation group also recorded a higher mean quality of life score. In the thoracic arm of the study, the prehabilitation group also showed a reduced physiotherapy length of stay and total hospital length of stay by approximately a day. Quality of life scores were comparable between the standard care group and prehabilitation group. In conclusion, the results show a trend toward reduced physiotherapy and total hospital length of stay. This means decreased hospital costs, improved patient experience, and enabling a safe and timely discharge. Physiotherapy prehabilitation may be the next step in revolutionising ERAS and cardiothoracic surgery, and in the current climate of a global pandemic, home-based prehabilitation could be even more important to prevent deconditioning with extended waiting times and lockdown restrictions. Current work within the MDT and senior management team is ongoing to set up a new prehabilitation service for elective cardiac and major thoracic surgeries at the Golden Jubilee National Hospital. Since the study, there has been a greater awareness of prehabilitation within the hospital, with the physiotherapy team receiving ad hoc referrals for preoperative prehabilitation. We continue to work in collaboration with the Cardiothoracic ERAS practitioner and establish links with the referring health boards. Our hopes for the future are to implement prehabilitation service and continue to evaluate this. All eligible patients will be assessed and provided with an individualised physiotherapy prehabilitation programme to optimise them and fully prepare them for the surgery and post-operative course. Thank you for listening.
Thank you so much, Katie and Fiona, for that really nice presentation, especially now in that COVID area. It's really important to have those kind of programs for the patients at home. My question would be, how do you keep the patients engaged and motivated at home? Are there alerts for the patients? Do you call them up, or how do you make them do the pre-physio?
So during the study, we didn't measure adherence to the programme. We asked them to fill in their diary, and they brought that when they came back to the hospital. So I think a learning point from that is we absolutely need to see what the adherence was, and that's certainly our intention when we do set up our prehabilitation programme. With the ad hoc referrals that we've done, we contact the patient weekly, and we reassess the exercise programs that we've given them if they're struggling with the same or they're finding them too easy. So that's a flaw in the study. We didn't measure adherence.
Nora, while you're just checking the Slido, are there any questions? And I'm just going to ask Fiona, in terms of measuring your outcomes, was there a consistency in terms of the other ERAS sort of interventions? So did you change anything about the anaesthetic, about the nutritional drinks, or anything like that?
No, apart from the prehabilitation exercise programme, we kept the care pathways exactly the same. because we really did want to measure functional capacity. I think one of the regrets that we did have when we applied for the ethical approval, we didn't use tidal volumes as measured by an incentive spirometer as one of our measures. And actually, that was probably one of the most significant measures that we had from the prehabilitation group. But because we hadn't given it to the standard care group, we couldn't obviously use it.
Well, it's always good to have lessons for next time.
Yeah.
Nora, thank you.
Fiona, there are some questions in the chat. One question is, how long is that prehab phase for the patients?
So it's very dependent. For the cardiac patients, it could be 6 to 8 weeks, because obviously the study was done before COVID. With the cancer waiting times for the thoracic patients, we were lucky sometimes to get 2 weeks, although there was some evidence to suggest that even a week's prehabilitation could have a positive impact on the thoracic patients. We've had 11 ad hoc thoracic referrals since the project finished, and what they have been mainly asking is for patients who are maybe being considered for surgery but possibly aren't physically fit enough, if we could prehabilitate them. And from the cohort of patients that we've prehabilitated, all of them have gone on to have surgery, and we've been given 4 weeks by the thoracic surgeons.
Okay, and another question from Evan Higgins is, what type of exercises do you ask the patients to do?
So in the study, it was a walking program. We asked them to increase their step count by 10% over a week. We gave them deep breathing exercises. We gave them an incentive spirometer. And because it was a study, we had to keep all the exercises very generic. Since we finished the study, we've added to that an individualised exercise program depending on the frailty and the fitness of the patient. So it could be sit to stand. We've done step ups. So we create a bespoke program for the patients as we assess them.
Perfect. Thank you very much, Fiona. And I hand over to Tara.
Okay, thank you very much, Fiona, and your colleagues for that presentation. I'd like to move us to the next presentation now and invite Sarah Jane Fashni to talk. The session that we're about to hear is Improving Patient Flow Through Cardiac ICU. So definitely dear to all of us, isn't it? So thank you.
Good afternoon. Quality improvement, a big issue in Scotland in recent years, has been strongly supported by the Golden Jubilee. With my interest in audit, I was seconded to a QI facilitator role for 9 months to promote an ethos of quality improvement in critical care, and was given time to join the Scottish Improvement Leader Programme. On this course, we learned the methodologies, presentation and practicalities of the QI approach, which, to be honest, seems less scientific than formal audit. The idea is it gives an early indication of whether a change in practice might result in worthwhile benefits. Part of the course was to design and carry out a project in your own department, demonstrating the use of QI techniques. We'd been looking at how we might improve the patient journey through cardiac ICU, and this seemed an ideal topic. You'll all recognise these bottlenecks at step down. Around the transfer from ICU to HDU, there's a raft of potential delays. A typical cardiac surgery patient recovers rapidly over the first 6 to 12 hours in ICU, and at the ward round the next morning, it's decided if they're fit enough for transfer to the high dependency. But they may not physically leave the unit for many hours. Many centres use a criteria-based policy in their transfer decision-making, and it seemed to me that many patients might meet this criteria quite early in the recovery, and I came up with this concept of unnecessary stay. So, for a project starting in April 2019, I thought we might look at how to achieve a modest, sustainable reduction in this unnecessary stay. Using QI tools familiar to many of you, Pareto charts, driver diagrams, PDSA cycles, etc., we identified changes in practice likely to affect ICU stay. The concept of criteria-based transfers was discussed with intensivists and surgeons, I have to say the most challenging and time-consuming part of the project, but they eventually agreed I could test the idea and collect data on a subset of patients running in parallel with our standard practice. We employed 2 healthcare support workers to help with the physical transfer of patients and to clean and prepare the bed space for the next patient. Bed busters. For the nurse at the bed space, standard practice became preparing for the next patient before the current patient was transferred. We tried phone handovers with HDU, but it really didn't work, so we abandoned it. One of our healthcare support workers took on the role of equipment lead, being responsible for its availability and maintenance. The senior charge nurses in ICU ran project awareness sessions to keep their staff informed and involved, key to this whole process. Early brainstorming sessions with experienced senior staff suggested that with 4 cardiac theatres running, to avoid the bottlenecks, we needed 4 vacant bed spaces by 11 AM. This short chart shows that at the start of the project, 81.7% of patients were still in the unit at 11 o'clock, having been deemed fit for transfer. As we introduced various changes in practice, there was a gradual improvement, but we were interested to look at and explain the big changes. The introduction of bed busters was dramatic, but then one went off sick. However, the remaining one did seem to be helping. The start of the criteria-based policy was encouraging, with a 30% drop. These are the non-policy patients. Then the dreaded COVID struck. Our routine cases were disrupted and projects like this were abandoned. Looking at the bed busters in another way with this run chart, the average time to clear a bed space fell by almost 40%. Then one went off sick and things became a little bit erratic. But the average improvement was maintained. Hopefully, with the advent of vaccines, etc., and our new ways of working despite COVID, this project might be rejuvenated. It certainly demonstrated to staff the benefits of the QI approach. Indeed, they're already asking about taking this forward and are coming up with ideas for our next projects. Thank you for listening.
Thank you, and thank you, Sarah, for that fantastic talk. I'm sure I will be echoed by most people here who say that this is a thing that challenges us all in every centre that we work in. I guess my, firstly a comment and then a question. I think the idea of bed busters is a fantastic way to move forward. It gives people the empowerment and the drive to be able to move people forward and making it someone's responsibility, which I think is fantastic. And I think you hit the nail on the head with the idea about changing the culture. Once the culture is right, everything else does seem to fall into place. And my first question is about the challenges that you faced as to what delayed patients from leaving ITU in terms of was it their clinical status? Was it the communication between the ward and the ITU? Was it the lack of ward bed? What did you find was the main challenge?
We actually did a bit of an analysis with the staff and asked them what they thought the problems were and where they thought the delays were. And then we actually measured and monitored the actual delays that were happening. And we managed to put that against a Pareto chart to show anecdotally what was happening versus the actual what was happening. And I think a lot of staff felt quite infuriated with some of the things that were causing the delays. But these patients that we looked at had already been deemed fit for transfer to the HDU. So it was availability of beds, availability of even finding equipment to try and take patients to the HDU. And this is where we thought about the equipment lead who was able to bring together all the equipment for the transfers and for patients coming in. The decision of patients that are leaving, this is how we brought about the transfer criteria. A lot of the criteria that's about was already happening, but it was just bringing it together and putting it down so that staff could follow it rather than it being various consultants' opinions on whether their patients can go. We're trying to bring it together and consolidate it a bit.
Perfect. I think Nora had a question as well.
I think it was kind of a bit answered with your question already, like kind of what were the main reasons for patients deemed to be unfit. But I think you had asked that before.
Mr. Kendall?
So lovely presentation, thank you. And there's, it's just a constant battle, isn't it, to avoid cancellations and get people through. Why were the conversations with the clinicians difficult? I would have thought, as we finished the session this morning, it's all about team, and the less time patients spend on ITU, the better. So what were the challenges?
A lot of them do want their patients to move on. Some would rather they went to the HDU before going straight to the ward. Others, it was, I think a lot of consultants don't like to have their own opinion about how their patients should be progressed. So bringing several consultants together to get them all to go in one path can sometimes be quite challenging. But this is the criteria, as I was saying, it was bringing together lots of different approaches to how their patients are moved forward. None of it was new stuff for them. It was all meeting certain criteria for them to be stepped down to the HDU or onto the ward. I think surgeons were very keen for me to collect the data on their patients before producing a piece of paper for certain criteria to be met. I think they like to have ownership of their own patients to decide when their patient can get stepped down to the ward rather than having a combined criteria.
Okay, thank you.
It's working together and getting everyone to work together with it and to take them on the journey with us. As I say, they were very accepting of the collection of data. It's just interesting that a lot of the criteria is almost embedded in our natural practice now, that it's changed the culture and it's helped us to move the patients on to the ward and to the HDU.
That's great, thank you.
So, Catherine, I think, is there one more question if we're very brief? Let's go to that.
Yeah, if we've got time, that would be great.
We haven't, but we will.
There's a question from Nicola Ray just saying that it's a very topical project, and she said that you mentioned telephone handovers were abandoned, and she's just asked why this was.
We had actually tried the telephone handovers from the HDU to the ward, and it was actually very successful, and they still do the telephone handovers from the HDU to the ward, and that was setting out a similar handover sheet so that the handover was made more simple. But there seemed to be a delay in trying to get the handover, and a lot of the information that staff wanted to hand over from an ICU setting to an HDU setting, they felt they couldn't get the specifics over in the length of time over the phone. They felt that it was were able to give more information in a face-to-face handover than over the phone. I think they feel that there's a little bit more information needs to be handed over within the critical care setting.
Okay, can I say thank you very much for that great interaction and presentation. I'm going to move to the next presentation, but just before I do, I can see that there is a whole host of people in the audience, so welcome to everybody. Hope you're enjoying the session, and please don't be shy with your questions. Pop them in the Slido while the presentation's on, and then we'll have them ready for the end. So, Sarah Jane, thank you very much, and I'd like to welcome our next speaker now, which is Suzanne Rawling. Suzanne is going to present on the question, does there need to be a surgeon at the table during robotic assisted thoracic surgery, otherwise known as RATS? So welcome, Suzanne. Thank you.
Hello, my name is Susie Rawling. I'm the thoracic team lead in the Cardiothoracic Surgical Speciality at Hull University Teaching Hospitals NHS Trust. I'm presenting today on the implementation of robotic surgery into the thoracic speciality, and discussing how that's allowed healthcare professionals' roles to advance and extend practice, answering the question, does there need to be a surgeon at the table during robotic assisted thoracic surgery, RATS? The results shown within this presentation are from May 2019, when the service was implemented, to the end of that year. There was very little thoracic robotic surgery performed in 2020 due to the pandemic. We had staff redeployment. Our only thoracic robotic surgeon became injured. We have since restarted robotic surgery this year, and we're looking forward to increasing the complexity and range of procedures available to patients. So why bother? We know the benefits of robotic surgery. Simply that it provides technological advancement, usurping the limitations of VATS, 3D magnified view, increased dexterity, reduced access trauma and blood loss, whilst maintaining enhanced recovery of a patient. Patients have less post-operative pain, shorter hospital stays, and a faster return to normal function, which allows the supporting therapies to be administered quicker. We have a lower conversion rate to a thoracotomy in comparison to VATS, lower mortality, and this is emerging technology, whereas VATS has limited expansion. With the approval from the Development Committee on obtaining a surgical proctor, we established a core robotic team of surgeon, anaesthetist, surgical care practitioner, and ODP, that's myself, covering the scrub and anaesthetic aspects of the implementation. Along with our industry partners, the core robotic team were given the opportunity to observe a RATS procedure at an established centre of robotic surgery. This allowed us to talk to our surgical peers and observe the differences between RATS and VATS, discussing changes to practice that were required. Our industry partners organised our staff training. It did take some time for staff to become familiar with the handling of all the technical aspects of the robotic platform. An evaluation before and after. So the skills of the proctoring surgeon were invaluable, not only to the resident surgeon, but also in providing feedback to all the team members, allowing us to continue to build on each experience and provide this efficient, high quality care. These are our emergency protocols. The roles of each team member were identified within each scenario and the expectations should these events come into play. The surgeon leads with this at every team brief, and it's this constant reinforcement which is the key to confidence of the team as it places safety as our top priority. So do we need a surgeon at the table? We currently only have a surgical care practitioner and a scrub practitioner at the table. Many registered practitioners have witnessed changes to their role as patient service provision has evolved. And organisations such as ours have recognised the benefits of utilising highly skilled and motivated workforce. All of our scrub practitioners are surgical first assists or currently undertaking a programme of study. The surgical care practitioner is involved in the surgical intervention, and the scrub practitioner becomes a surgical first assist for some aspects of the operation, such as guiding the robot in, inserting and removing instruments where necessary, camera holding, etc. With the addition of the basic surgical skills course, practitioners can be further utilised, which can improve turnaround times and promote greater theatre utilisation without compromising patient safety, and is something that we're looking to implement in all of our robotic specialities. Our operative times have a nice downward trend, which we're hoping to continue. We have only one instance of a prolonged air link and one chest infection to date. We have 0 conversions to a thoracotomy without a surgeon at the table. So what have we learned? We've learned that we can successfully deliver thoracic robotic services to our patients with very favourable results without having a surgeon at the table. The established core team ensured consistency, consistent learning and excellent team working overall, and we've created a team with a real desire to develop and expand the range of services that are available to our patients. We now have a robotic suite and an additional XI robot to add to our SI. We have another thoracic robotic surgeon in training, And we are looking to implement this basic surgical skills to all of our surgical first assists within the robotic suite to cover all of the specialities. This is also going to be part of the recovery plan for COVID-19, as it will increase capacity. More patients will benefit from the robotic services and boost waiting times. And of course, we're embracing emerging technology. So we are part of this new generation where technology allows, say, surgeons around the world to collaborate in complex cases without any movement. We've achieved this mainly with a positive attitude and really excellent communication by those involved in this process. We're an overall remarkable team effort. Thank you for watching. Happy to answer any questions.
Thank you so much, Susan, for your really good presentation. It's a very interesting topic, and the robotics are the future, as we all know. How long is there a special training for you for, like, when you want to be one of those one of the robotic team?
No, we're all surgical first assists in thoracic surgery. So we are continuously learning and training. We're just about to embark on the XI robot that's starting next week with one of our other surgeons that's recently trained. So we'll have training for that this week, and yeah, just continue to develop and rotate staff through, so those with experience becoming role models for the other surgeons and surgical staff.
And I think it's brilliant, and I believe the consistency is great. And but how do you think shall the doctors, like the trainees, get used to the robotics when we don't use them, or when we don't need them at the table anymore, like just the first steps?
Yeah, we don't. The registrars are starting to get quite interested. We do have them in other specialities. It's just not something that we've needed in thoracic surgery. They do come along and try and get involved.
Okay. Does anyone of the chairs have another question?
I'm going to just sort of say thank you very much, but in the essence of time, I think we'll move on, if that's all right. So thank you very much, Susie. Very good presentation.
You're welcome. Thank you.
Well done on your achievements and the team that have done it.
Thank you.
Thank you. So I'd now like to invite Siobhan Williams. Siobhan wants to talk to us about a simple solution to optimise prescribing post-cardiac surgery, a quality improvement project. Thank you.
Good afternoon, everyone. Thank you for attending this session, and thank you to the course organisers for a brilliant day so far. My name is Siobhan, and I'm a junior clinical fellow working in intensive care. Today I will be talking about a quality improvement project which I undertook at St Bartholomew's Hospital in cardiac critical care alongside my colleagues Dr. Lee, Mr. Yates and Dr. Dooley, where we created a simple solution to optimise prescribing following cardiac surgery. The reason we started this project was the fact that we noticed that not all routine cardiothoracic patients were receiving the optimum post-operative medications. To see if this was a problem or just a few isolated events, we created a quality improvement project to further investigate. To begin, we picked a sample population. In this case, we chose patients who underwent the routine cardiothoracic procedures stated here, those who had uncomplicated surgery, and those who were extubated on the evening of day 0 or the morning of day 1. To collect our data, we reviewed the post-operative prescribing on day 1 for patients that fell within our sample population, both before and after the morning ITU ward round. Here are the results of our initial data collection. As you can see, the prescribing of these 9 medications on day 1 post-operatively was poor. In green, you can see the data collection before the ITU ward round, and in purple, you see the data collection following the ward round. We collected data from 60 patients, and you can see that before the ward round, for example, diuretics were only prescribed in 23% of cases and bisoprolol in 35% of cases. Dual antiplatelet therapy was required by 28 of the 60 patients and was only prescribed in 21% of these cases. Even following the ward round, you can see that there was still poor prescribing across all 9 of the medications. And for example, diuretics were only prescribed in 38% of the time. We presented our findings within the department and created a checklist that you can see attached here on a sample drug chart in yellow. We created this to act as an aid memoir to clinicians and a reminder of the routine medications to consider prescribing post-operatively. Following the rollout of our intervention, we waited 2 weeks before re-auditing the data. This graph illustrates the data collected on prescribing before the ITU ward round. In green, you can see the data collected before our intervention, and in blue, you can see the data collected after the intervention. Again, we collected data from 60 patients, and it is clear that following the intervention, there has been a clear improvement in prescribing of all 9 medications before the ITU ward round, with the greatest improvement seen in prescribing of prophylactic low molecular weight heparin, statins, proton pump inhibitors, and laxatives, and the least improvement noted in the prescribing of diuretics and dual antiplatelet therapy. This next graph illustrates the data collected on prescribing after the ITU morning ward round. In purple, you can see the data collected before our intervention, and in blue, you can see the data collected after the intervention. You can see that following the intervention, there has also been an improvement in prescribing after the ITU ward round. However, this is not as marked as the improvement in prescribing before the ward round. Interestingly, following the intervention, there has been a slight decrease in prescribing of dual antiplatelet therapy. However, you can see that across the board, this is the one anomaly. To investigate if our results were statistically significant, we performed a 2-tailed paired student t-test, which illustrated a statistically significant improvement in prescribing following our intervention in both the pre-ward round and post-ward round data groups. In summary, we discovered an average improvement in prescribing across the 9 medications of 39% prior to the ward round and an 18% improvement following the ward round. We noticed the greatest improvement in prescribing before the ward round for prophylactic low molecular weight heparin and laxatives, and following the ward round, the greatest improvement was seen for diuretics, bisoprolol, and laxatives. In conclusion, we have demonstrated that a simple checklist improved post-operative prescribing in routine post-operative cardiac surgical patients with statistical significance on day 1, both pre and post-ITU ward round. Thank you for listening today.
Thank you, Siobhan, for that fantastic presentation. It's very clear by your results that your implementation of the things that you've done has massively improved the prescribing post-cardiac surgery. So that's really, really good work. I've just got 2 questions personally. Have you included in your data collection whether any of this data was, or any of these prescribing was done by non-medical prescribers in comparison to your medical colleagues, or is it just medical colleagues that you looked at?
No, thank you for that question. It was just medical colleagues that we were looking at, and what we looked at was after the ward round, and those ward rounds were joint ward rounds with intensivists as well as the surgeons would also be there. Interestingly, sometimes there were the pharmacy team on the ward rounds, but because this was the time where COVID was just starting, it was uncommon for them to actually be there. But it would be interesting to look at.
Yeah. So do you not have ACCPs in your intensive care yet, or you do?
So we do have ACCPs, but they're not prescribing currently in the intensive care, but help with other things.
That's perfect. And I guess my next question is that, like I say, you've had fantastic results moving to this point. How are you going to push this further so that your results, specifically, I think you mentioned diuretics, bisoprolol and dual antiplatelets, prior to your ward rounds, how are you going to implement change to try and improve these moving forward?
So that's definitely something we've been thinking a lot about, and we've been thinking more about education and really talking to the intensive care doctors that commonly rotate through, so they understand and know what medicines are prescribed and why they are prescribed. It's also something that we've started to look at, making a more permanent, instead of a sticker on the drug chart, but making something that's there for months going forward, just so that it's then continued, even though some people have moved on.
Yes, perfect. Yes, Mr. Kendall.
Siobhan, great presentation, thank you. I don't know if you heard one of the early presentations, but they talked about the surgeons and the anaesthetists having individual views on how patients should be managed, and it sounds like you've got quite a good consensus in your unit. Is that a fair comment, or how does it feel to you?
I feel that there is a good consensus. I think the communication is key, and there is quite very good communication that I've seen on our unit. There is sometimes differences between consultants, but I feel that with communication and the talking, it's normally understood following that.
Good, thank you.
And do you have post-operative prescribing templates, for example, because as you said, the doctors are rotating, or the fellows? Do you have some templates like which they can, just click and then of course review, but do you have something?
Our prescribing is still all on paper, so templates and things like that isn't something that we've been using. So it was something that we were trialing with this checklist, but we made it still very clear that it was only an idea for doctors of what they should be prescribing, but still the onus is on the doctor if they choose to prescribe those medicines.
I see. Thank you.
Tara, do we have time for more questions?
We're out of time, really. Is there anything that could be summarised very quickly? Is there anything in the Slido?
There's nothing in the Slido. I just wanted to reiterate what you mentioned there about pharmacists. And I think quite often the role of pharmacists post surgery is undermined and undervalued, and the way that they help us with our prescribing for these patients is fantastic.
No, definitely.
So I just want to make a point of thanking pharmacists, and we've had some fantastic pharmacists where we've worked, so we do really appreciate the hard work that they do as well.
No, definitely. No, thank you all.
And Helen's just put one comment, sorry, just to say that electronic prescribing is coming soon.
That is exciting.
And always will be in the future.
Yes, it will.
Thank you very much to the panel, and thank you, Siobhan, for your questions and for answering so well. And definitely I would concur with Catherine's opinion of the multidisciplinary team. Where would we be without pharmacy? Yeah. So definitely. So, and electronic prescribing saves a real headache in terms of sort of scopes of practice and building in the sort of the barriers to mistakes. So roll on with it. So, right, thank you very much. I'm now going to move to the next presentation by Elaine Tay, and Elaine's going to look at the impact of a nurse-led chest drain clinic on the hospital length of stay. So invite her presentation and then Elaine to questions afterwards. Thank you.
Hello, I'm Alice and I'm a foundation year 2 doctor. I spent some time on the thoracic surgery unit of the Bristol Royal Infirmary during one of my F1 rotations. During that time, we did a service evaluation study on the impact of nurse-led chest drain clinic on hospital length of stay. So, as I'm sure you all know, prolonged air leak following thoracic surgery is a common complication. It's undesirable as it can lead to complications such as empyema, and it can also lead to prolonged hospital length of stay, which in turn leads to its own complications such as hospital-acquired pneumonias and DVTs, as well as increasing healthcare costs. So in our unit, we implemented a weekly nurse-led chest drain clinic. So for our patients who had prolonged air leak from their chest drain following thoracic surgery, but who were otherwise well, We switched their toe pads to a flutter bag and we discharged them home. They then came back to our weekly nurse-led chest drain clinic, where their chest drain and any other complications were assessed, and if the air leak had resolved, their chest drain was removed. So we did a retrospective study where we looked at all the hospital records for the patients who attended our nurse-led chest drain clinic from January to December 2019. We looked at the demographics of these patients as well as the complications that they experienced. In total, there were 31 patients. The mean age was 64 years. There were 7 women and 24 men. 39% of our patients had benign disease, meaning that the vast majority were cancer patients. This table just shows the type of operation that our patients had. And as you can see, the majority of our patients had either a lobectomy or bilobectomy or an other procedure, which includes empyema washout. This slide is also just showing some more of the demographics of our patients. The majority of our patients were either smokers or ex-smokers. This is expected, as we know from the literature that smoking is a significant risk factor for prolonged air leak post-thoracic surgery. The median FEV1 was 68%, which shows a moderate reduction in lung function, and the median TLCO is 69%, which is a mild reduction in lung function. Again, this is expected as most of our patients in thoracic surgery have a reduced lung function. This table shows the complication rates that our patients experienced. So most of our patients, 39%, had no complications at all. Superficial wound infection was the second most common complication, and this, along with poorly controlled pain, can be managed in the community. 6 of our patients had to be readmitted. 2 of these had to be reoperated due to an empyema. 3 of these patients were treated with IV antibiotics, 1 for an empyema and 2 for lower respiratory tract infection. And 1 of our patients was readmitted for a trial of drain clamping. These complication rates are comparable with another similar study. So overall, the median number of days that the chest drain was in place for our patients was 20 days. So this means that the median number of hospital days saved per patient was 11 days. So therefore, having a nurse-led chest drain clinic is a really efficient way of managing post-operative prolonged air leak. It allows our patients to recover from their thoracic operation at home, reducing hospital-associated complications, and indirectly improves flow through our unit and reduces cancellation of surgery. And many thanks for listening to my presentation, and I welcome any questions. Thank you.
Thank you very much, Elaine and Alice, for this brilliant presentation. It's very interesting. We have exactly the same in Hatfield Hospital with a nurse-led chest drain clinic. How did you manage to bring the patients in every week during the COVID pandemic? Did you have any problems with that?
Yes, so during COVID, we tried to reduce the number of patients that we sent home with chest drains, and I think we were left with a couple. Unfortunately, most of them were sorted out quite quickly. There was only one patient whose drain, it was just not safe to take out. So in the end, the nurses had arranged with her to, so she'll take a photo of her wound, and they'll just call her. And fortunately, we managed this patient quite well from the community like that.
It's a good point that you're saying, like the photo, because we're trying to implement like a photo or even a video, like for the patients to upload from home, so that we don't have to bring them in every week, to just like save those or like make it easier for both patients and for us in the clinic. Are you covering your patients with antibiotics, given the fact that you had, I think it was 10% of patients coming back with an empyema who were discharged with a chest drain in?
Not routinely, unless they change it, because I've left Bristol for about 6 to 9 months now. But before I left, no, only if indicated for empyema reasons, because some of them did have long-term drain because of empyema anyway. But for the lung resections or other elective procedures, no.
Okay. Thank you, Elaine. Tara has a question.
So thank you, Elaine, and nice presentation from Alice. My question is really around, and it may well be defunct now, but it's around the challenge of when you want to start up a clinic, finding a clinic space to run it in. So was that a challenge initially? And bearing in mind the sort of the new ways of working with COVID, are you going to move more to the video and stay from that point of view, as you just said?
So pre-COVID, what we've managed to arrange in Bristol is rather than having a clinic space, the patient comes to the ward, although it is recorded formally as booked in as a formal clinic on the system. They just come in on the ward. We have the facility of a side room where our CNS will review and assess the patient and do the basic care, changing of dressings, changing of Cortex bag or x-rays if required. During COVID, all the clinics in Bristol were done via telephone or video. I'm not sure. There was one of my colleagues did present our result, our experience with this at another parallel session. The trouble with video is I think a lot of our patients had trouble connecting to the video, so always end up being a telephone conversation. I think the consensus from that review of our experience was that about half the patients are quite happy with telephone or virtual clinics, although some prefer to come face-to-face. And I think, personally, I'm not sure about how our CNS feels. I know, they would prefer to see patients, but personally, I do find it's a bit of a tricky challenge because sometimes you need to see them when they describe to you. And even with the aid of a video or photos, it's just easiest to examine the patient yourself, to have a look at the wound. And as I said, I've left Bristol for a few months now, so I'm not quite sure where they are at in terms of coming back to the pre-pandemic level, because during the pandemic, the thoracic ward moved because we have a lot of side rooms in our usual ward. And because of COVID and the need for isolation for a lot of the non-elective patients, we had to give up our ward and swap with the surgical assessment unit. So I think there's limited space in the current ward that they were at before we left. So I'm not sure what the current plan is. I'll probably have to find out from our CNS colleagues there.
Elaine, there's probably one last question from the auditorium from Carol Herpich, and she's asking if that clinic is in an outpatient setting and when you have to remove, or when it's ready, when the drains are ready to be removed. Are the patients, are the drains taken out in that outpatient setting, or are the patients going to the ward?
Well, usually the patient is seen and assessed by our CNS in the side room on the ward or a treatment room. And if the drain's ready to come out, it'll be removed on the ward, but not as an inpatient.
Okay, so discharge same day.
Yes.
Okay, thank you.
Nice. Thank you.
Okay, so thank you very much. I think there are a couple more questions from the panel, so I'll ask you maybe to put them in the questions, or maybe we'll see if there's time at the end. But in the essence of time, I'm going to move to our final presentation before Bhuvna speaks to us. So I'd like to welcome, a very warm welcome to my colleague that I'm privileged to work with, apart from Catherine, is Amy Millichop. Amy's going to share with us what's been a team effort from them all to develop a service evaluation of an adult aortic service, exploring the potential impact of ACP roles in service delivery. So, Amy, welcome.
Hi, my name's Amy Millichop, and this is my presentation of a service evaluation of an aortic surgery service, exploring the potential impact of advanced clinical practice roles in service delivery. Aortic surgery is a subspecialty of cardiothoracic surgery and is a highly specialised area only performed at a limited number of centres across the UK. Patients with aortic disease often require lifelong surveillance, and European and American guidelines provide an overview of practice to facilitate clinical decision-making. However, there is a distinct lack of national framework, resulting in varying practice across the UK. With an ageing population and improved imaging facilities, the incidence and diagnosis of aortic disease is likely to grow, resulting in an increased number of patients requiring management decisions, intervention, surgery, and extended surveillance. This will have subsequent impact on workload for existing teams and also offers an opportunity for advanced clinical practitioners to develop services. Furthermore, gaps in the patient pathway, including clinical review throughout the surveillance period and communication following the MDT, can be improved, enhancing the patient's sense of security and education. The aim of the service evaluation was to define and review the existing aortic surgery care pathway at the QE hospital in Birmingham and explore the potential impact of an ACP role in that service delivery, making recommendations for future service development. A mixed methodology approach to data collection was used, combined with a scoping literature review. As complex high-volume aortic surgery is highly specialised, a scoping literature review was chosen to scope the wider area of cardiothoracic services, exploring the potential impact of ACP roles in similar types of service. Quantitative data was collected and included length of stay and cost of outpatient clinics, and qualitative data included review of complaints data and a patient journey walkthrough. This was useful to gain an insight from the patient perspective, an essential component in any quality improvement programme, whilst adhering to social distancing restrictions in place at the time of the evaluation. Aortic centres across the UK and in Houston, Texas were also visited as part of the peer review process in 2019. So the findings were 16 papers met the inclusion criteria for the scoping literature review and were included in a narrative synthesis. The transferability and generalisability of the literature was questionable due to the highly specialised area of aortic surgery. Sometimes things weren't easy to transfer to our specialty. Key themes in similar services were based around the impact of the ACP on patient satisfaction and length of stay. Trust data collected included the length of stay, complaints, and cost generated in outpatient clinics, and this provided an overview of our current service. The results were not compared against other centres, and this was due to the availability of information as a visitor. However, this would have enhanced the service evaluation. Types of surgery being performed at each centre would, however, need to be taken into consideration, as an ascending aorta replacement, for example, would likely have a reduced length of stay compared to someone who had perhaps a thoracoabdominal aneurysm repair. The varying scope of ACP practice in aortic centres was notable on peer review, with a lack of clarity around the role of the aortic ACP and what it should encompass. To conclude, an aortic ACP has the potential to positively impact on the patient pathway by enhancing practice and developing new ways of working to improve quality and productivity, whilst ensuring sustainability for the future. The evaluation did highlight that the income generated from ACP outpatient services is the same as any nurse-led clinic, and that there is no specific ACP outpatient tariff. This is not peculiar to one trust, but to the NHS overall, and it is proposed that this is reviewed at a national level to ensure that ACP activity is captured and recognised at the level it deserves. The work so far. So we, as a team, put in place a rotational aortic ACP role for existing members of the team over a period, who step into the role for over a period of 4 to 6 months. The 6-month person allows for handover for the next member of staff in the role. A weekly ACP virtual clinic has been introduced since July 2020, with 7 20-minute slots generating associated income. ACP presence at the MDT, identifying who should be reviewed in the virtual clinic with the lead aortic surgeon. And we've split that down into 3 types of patient. Those who are new to the service, so new referrals from GPs or perhaps incidental findings from CT scans. Those who are being discharged from the service, who may have been under the service for several years under surveillance. And those with changes noted on routine surveillance scans. Also, the production of a patient information booklet, which has been very kindly sponsored by Terumo, has been developed by all of our team, but specifically one of our colleagues, Catherine, and ongoing development of local guidelines and policy. Thank you.
That was great, Amy. Thank you. I've got a question for all of you, because this has a major impact. And if you've got a team of advanced practitioners, do you see the potential for someone doing the mitral, someone doing the mesothelioma, someone doing the aortic, and then you rotate and you get that experience and you give the patients a better experience? What potential do you think there is?
Yeah, I mean, the principles could definitely be applied to all of those specialties. And what we found as a team, it's really great for our learning, because when you're doing the same sort of, I mean, we're ward-based and we did used to do some pre-admission clinics, but it would be good for the challenge, and it tests our knowledge base and stuff. So we've all learned, especially those that have been involved in the aortic program so far, have all learned so much in 12 or 18 months about aortic surgery. And it is complex, and it's not something that you can do when you're new to the role. So absolutely, I think that the principle could be applied to all those specialties.
If I could just add a quick comment as the lead for ACPs, I think it's part and parcel of leadership to give everybody the opportunity to function across all 4 pillars. And so continuing to innovate and give people things to move forward is part and parcel of my role in augmenting everyone's development. So leadership of self, leadership of others, clinical education. You can see here that Amy and Catherine are, playing a big part in the meeting. So I'm incredibly proud of them and their colleagues as well. So Catherine, we've hoodwinked your bit, sorry.
That's fine. Thank you, Amy. I just want to point out as well that this project has been done largely from Amy's dissertation for a master's. So thank you for that, Amy, and it's been really, really helpful for us. Through that dissertation, you actually had some really interesting points regarding the ACP role and CNSs, and the role that they have and the position that they have within these particular scenarios. So I was just wondering if you were able to give us a little bit of an idea of what your view of CNSs in comparison to advanced practitioners are.
Yeah, so I can't remember the title of the guidance, but it was released. The International Conference of Nurses in 2020 released a new paper to differentiate the role between advanced clinical practitioners and CNSs, because I know that there is so much overlap and there's so much literature and so many different roles. I think there's about 800 and something advanced roles which encompass CNS, nurse practitioner, advanced clinical practitioner, and lots of other titles, and essentially that policy from 2020 said that a CNS is an expert in their in a specific area, and they look at that comorbidity for a patient, but don't look at the patient as a whole, whereas an advanced clinical practitioner is looking at the patient as a whole. And that then led on to discovering that although many ACPs are conducting advanced clinical practice-led clinics and obviously being paid at Agenda for Change advanced clinical practitioner level, unless the trust is booking that clinic under a consultant name, that advanced clinical practitioner doesn't achieve and doesn't make any more income in comparison to any other nurse-led clinic, which I thought was not what I was expecting. So essentially, all nurse-led clinics generate a set tariff, and any other clinic to achieve a higher tariff than a nurse-led clinic would need to be under the premises of a consultant, even though the consultant's not doing the clinic. So I think that the way that advanced clinical practice is going with development of Health Education England funded MSc level courses, and then perhaps movement into nurse consultants, advanced clinical practice consultants, that's something that should be looked at national level.
So can I just, sorry, Catherine, I'm going to have to cut in now and thank Amy because of time, but I think that's an excellent summary, Amy, and many of our CNSs have very good advanced skills, but it's about whether you practice across all the 4 pillars and whether obviously you'll be able to take a job plan with those advanced roles. So I would just like to draw this part of this session to an end from my point of view by thanking all my chairs and all the sponsors, particularly Consent a Patient for this afternoon, and all the speakers that have given us and shared all their expertise and excellent work. What we're going to do now is we're going to welcome our SCTS representative for nurses and allied health professionals to the floor, Bhuvana, and Bhuvana is going to share a video with us on the future of the society from our perspective, and then probably take the floor for a few minutes. So, Catherine, thank you very much. Nora,
thank you. Thank you all.
Mr. Kendall, thank you. And
thank you.
Final speaker, Amy, thank you. And thank you to the IT support for this session as well. Bhuvana, welcome and congratulations on your new role. You're a very popular appointment and we're delighted to have you.
Can you hear me, Tara?
We can hear you lovely, but I prefer it if I could see you. Where's your face?
I'm here. Thank you so much.
Hello.
Thank you, everyone. Can we have my presentation, please? Then I will just say a few words. And thank you so much for today's all presenters and also faculties. Thank you so much.
I'd like to thank Helen as well for all her work previously.
Good evening, everyone. Thank you so much for coming today and listening to my talk. I am Dr. Bhuvaneshwari Krishnamurthy, who has taken over the NHP Nurses and Allied Health Professional SCTS National Lead from Mrs. Helen Munday. What I want to do today, I want to just talk about my 5-year strategy about transforming the SCTS Nurses and Allied Health Professionals stream. And why do I want to do that? As you know, everyone knows that when you have a new leader, they want to change for the better of our members. So what is our new SCTS subcommittee is going to look like? As you all know that, as I heard quite a lot from everybody was saying this is only a nurses oriented program. It was not combined with the allied health professional. And I agree, because our nurses, we always have time, and especially myself is a nurse who has become a surgical care practitioner who have taken over, and I understand your frustrations as well. That's what I did is I did have a telephone consultation and discussion with the SCTS executive team and also the current leads to develop the nurses and allied health professional team, and everybody agrees, and it is very important for us to see those changes to make our members to be happy and also part of it. And also we decided that it is important, myself thinking that it is to have a new subcommittee leads, and I will explain why we need them. And also development of the new structure with the current team involvement to make them as part of this transition of the old executive committee as well, and also bringing the new members to be together as a one team. And also writing a new job descriptions with educational events and new innovative ideas to be embedded within that. It is very, very important to be together. So what I meant about the new subcommittee team member and the NAHP structure, how it is going to look like. Many of you have seen that I started in February 2021, already advertised for the post, and some of you have applied. Actually, we have got almost 28 applications and we are shortlisting them. So why do we need this structure? The importance of having this structure is not only as a nurse myself, I can't know what a physician associate needs or what is occupational therapist and also physiotherapist and operation department practitioners and surgical care practitioner. Of course, I am myself a surgical care practitioner. That's what you have seen. And also you have said everybody that I'm mainly focusing on the nurses or cardiac or thoracic and also a surgical care practitioner educational program. That's why we need a different structure of having a different allied health professional together in the team. That will make a difference. And then everybody will know what are your needs, what you need for your educational development, for your career pathway development, and also to be in a team as a surgical working life. That's why we are going to advertise from the advanced clinical practitioner to thoracic surgery, because the thoracic surgery is always, most of you complain that we never ever get a more involvement. That's what is important, to have the thoracic surgery nurses or allied health professionals to be part of it. And education, I am already sitting on those things, but only for a few more years, then I will be giving it up. And we got Emma, who has recently appointed from Papworth Hospital to be a part of the transplant team. And our Professor Julie Sanders already leading the research, and she has got already setting up a future research subcommittee lead with a few other subcommittees, rep with them. And surgical care practitioners, we know that the president of ACTA SCP is going to sit in this. That means both of the organization will work towards one goal of developing the surgical care practitioners, whether it's education or whether it's going to be a career pathway, whether other professional needs will be achieved. It's interesting to see that how many operating department practitioners have applied for this job, and I'm so glad that they did. And physiotherapists, we already got 2 physiotherapists in our team. One is Zoe, who is looking after the communications and website, and we want congenital specialist allied health professional as well with nursing, and critical care practitioners, equality and diversity lead, especially physician associates, to start with professional standards. So these are the team is going to be. I know that this is a starting program we have started, and in a year time, hopefully we will be well developed and have a one strong NAHP structure within our SCTS to develop a professional focused team for the better patient care and also for our members. So fellowship and career advice opportunities. I know that every quarterly we are asking for, calling out for the fellowship opportunity. Please apply. This will give you a £5,000 to visit to the other unit nationally or internationally to develop a important structure, whether it can be a ACP team or SCP team or perfusionist or anything. It doesn't need to be new innovations you can talk about as well. You can talk about your professional development. You can go and visit other unit and bring those whatever you have learned and disseminate in your local or develop within your local unit and disseminate through our SCTS to everyone. So please apply. We got only few applications, and I would like most of you to apply for this competitive IANSCO SCTS University Award Fellowship Award for the NAHPs. And also, this can be, if you are going to be part of the CTS, and this will be whether you can be a member today, tomorrow you can be a subcommittee rep, and then you can be a subcommittee lead, and one day you can be like me. That's what I started my career 15 years ago within the CTS, to be part of it and my voice heard. And support your colleagues to apply for the funds. They can go nationally or internationally. It doesn't need to be you. Maybe you are not ready to do it, but you can support your colleagues to do that. And development of the new learning using the fellowship opportunities and supporting the local colleagues to disseminate the best practices nationally. I know that most of you, whenever I meet, you all saying that, oh, we do fantastic in seminar discussing case-based discussions, or whether it is going to be talking about your new innovations or guidelines or practice. Please come, and we are open to everybody, especially for our members, to disseminate the local practices to nationally. So what I am doing as a CTS lead for that, so we are going to start an informal seminar series soon, within few months, so you can come and be part of it, and you can discuss a case-based discussion, or you can problems, you can bring it, and we will have experts to give you an advice on those things. And important of the fellowship is how it is going to help is to support your local colleagues to move up the career ladder. As I said, I started from a member, then I become a presenter, then I started doing educational courses, then I become an educational subcommittee lead, and then now a CTS NHP lead with all your support. Without your support, that will never ever be happened. So unit rep, the other important things what I want to start is a unit rep representative engagement program. I know that my previous lead, Helen, started this, and it was really interesting to hear from her as well, and I want to continue this. So I already started the introduction meeting from April to June, but still I'm going to continue as I know that the COVID pandemic has stopped quite a lot of us and most of you have overworked and the cases are getting more and more and very busy, but still 15 minutes of your valuable time will be very, very useful for me and also useful for your department. And what I want to do with the unit rep, I will be talking this again to you on the day with a different presentation, but summary of that is inviting all of you who are the unit reps to be part of the educational faculty in webinars and also face-to-face teaching and also one-day virtual annual course, because it is important for us, you to be part of our faculty. And also this helps us to and also help you to be a mediator to pass the SCTS informations, especially fellowship or educational courses, CPD points, which will be very valuable for the validations of NMC or HCPC. 2 meetings in a year to draft a plan for the next 6 months target and 1 annual report, which is very, very important. That will be published in the SCTS bulletin about your departmental activities, achievements and developments, what you have done, what you are planning to do, which is important for us as well. And also active participations in the development of educational materials, policies, guidelines, and come and share your fantastic video of a surgery or a chest drain in removal or chest drain insertion, anything, whatever you think is important to disseminate to our members, please come and be part of us. Anything for us, we can help you to, for the videos, for the faculty or educational, we are happy to support from the SCTS. A new membership engagement taster sessions, we are planning to start once all the unit rep meeting has been finished. So what is the educational plan for the year 2021? So as you have already seen, what we are doing is a 12 cardiothoracic webinars mainstream. That's what our plan is, which will be, I will be one of the educational course director and I will have one of the AHP focused subcommittee rep as well in those streams, and they will be running like physiotherapists or operating department practitioners or perfusionists. They will be part of designing the courses with me and with the other team within our NAHP. And also most of you always say that always the cardiac courses are being done. So now we are adding an additional thoracic webinar sessions as well to give thoracic faculties to be part of it, and also thoracic nurses and allied professionals get value of our SCTS courses. SCTS annual conference, as you know that which I am talking now, we have a university day with a variety of speakers, which is always very, very interesting. It is sad. I always like the face-to-face. It's not only face-to-face, will give us a social interactions, and also we can share what we learned throughout the year. So this year is annual program. 2 virtual cardiothoracic courses, which most of you attended on the March on the thoracic online, and the next we are having a June 2021. We have a cardiac, then we have a physiotherapy course, and also transplant courses and endoscopic vein and radial artery courses coming in July and August. Please keep your emails active. In addition to that, as you know that most of the surgical care practitioners, as me being a surgical practitioner, can't attend the meetings because of the workload during the SCTS meeting. So we are, as SCTS and ACTA SCP has planned to have a blended annual conference in November 2021 for the SCPs, for the surgical care practitioners. So equality and diversity and inclusion opportunities, this is a very, very important, as I come from the diverse backgrounds, and it is important. Thank you so much for listening. Actually, we have to close it because the time is running out. And thank you so much. So I want to say that thank you for listening, and also it will be uploaded. One thing I want to say is what we are starting is just expanding our team to be part of it, to make sure that we all are inclusive of all nurses, allied health professionals. And thank you so much for giving me opportunity, Mr. Kendall, to be part of it. And hopefully we will get a bigger team and more voices will be heard. And next year we are going to really flourish it. That's what I can say. Thank you so much for coming. And all the presenters, all the SCTS team, all the faculties, and of course, Mr. President, Thank you so much for giving us this opportunity. It's an absolutely wonderful virtual meeting. Hopefully next year we will be blended approach. Thank you, everyone. Mr. Kendall, would you like to say something?
I would, Bhavana, thank you. I've just been saying that the presentations have been brilliant. We started in 2005 with a group of colleagues who were frightened even to come to the meeting, and they were very frightened of being in the exhibition area with the surgeons. We have come on a huge journey, and we're only halfway through, as your presentation shows. So let's keep working together. Let's keep having fun, enjoy our work, and support each other. It's a pleasure to watch, and thank you for all your energy, Bhavana. Thank you.
Thank you. I would like to say thank you as well to Daisy, who is one of my co-lead, who sits and does the absolutely amazing virtual. It was going on, and she has done a wonderful job. Daisy, hats off to you. Very proud of you, Daisy. Tara, we can't hear you.
Sorry. I just want to sort of add my thanks to Daisy, who's been absolutely amazing in leading this meeting, and all the hiccups that they've had along the way to bring it to fruition, along with the rest of the team. So from the CT allied health professionals, thank you to Daisy, all our staff at the Society, and everyone else that's brought it together. And can we just recognise Helen again for all her work previously? Thank you, Mr. Kendall.
Thank you. Thank you.
Did you want to say something?
We had a lovely video celebrating Helen's achievements and her very varied interests and all her wonderful work. And Bhavana, I think you've shared that already, haven't you?
Yeah, I think it was done. I think.
Yeah.
Sorry, I couldn't able to come yesterday. The clinical commitments, I have to go.
And Helen has done a huge shift as the lead AHP. She's left it in really good condition for Bhavana to take forward. So it's been a pleasure to work with Helen, and we will miss her, but hope she stays around and hope she stays involved.
Okay, I think it's time for us all to say goodbye.
Bye.
Thank you.
Bye, everyone.
Bye.
Have a safe journey, everyone, if you are moving. Bye.